and welcome to Changing the Ovarian Cancer Story, the podcast from the World Ovarian Cancer Coalition. Together, we are shining a light on the most lethal of female cancers. Did you know that 70% of women diagnosed with ovarian cancer live in low and middle-income countries, or LMICs? Well, a groundbreaking new study from both the Coalition and the International Gynaecologic Cancer Society gives us the first comprehensive picture of the experiences of women with ovarian cancer in low and middle-income countries. It's called the Every Woman Study LMIC Edition. And now, one of several papers on the results is being published in the Lancet Obstetrics, Gynaecology and Women's Health. And I'm delighted to say that later on we're going to be joined by the editor-in-chief, Sonia Muliyil. Well, also later joining us from Nigeria will be Dr. Aisha Mustapha, a consultant obstetrician and gynaecologist. Dr. Aisha was a clinical lead on the Every Woman study in Nigeria, and she's also the technical lead on a really, really exciting project in the country that she'll tell us all about through the course of the conversation. But first, what is this new piece of research, the Every Woman Study LMIC? And what is it telling us? What does the data tell us? Well, to break it all down in hopefully layman's terms, I'm joined by study lead Frances Reid from the World Ovarian Cancer Coalition. Frances, it's so great to have you on the podcast. Now, this study has been your baby, so to speak, for quite some time now. First off, tell us, why was it needed?
It was really needed to try and help quantify what women were actually experiencing. We'd previously done a study, the Coalition on its own, looking at experiences of women, and we did it online. And most of the respondents came from high-income countries, 95% of them. And as you said in your introduction, 70% of women in the world who have this disease live in LMIC. So we had a real issue there with a data gap. And it was through meeting with clinicians who recounted experiences of their patients, and then working and talking with the International Gynaecologic Cancer Society that we decided it was something we could take a look at, to look at developing the study to be run through hospitals this time in these countries, so that we could really grasp what was going on from women's knowledge of the disease, their family history, their experience of getting a diagnosis. Did they have symptoms? What route did they take? Then the impact of treatment on them, not just the physical impact, but the emotional impact, the practical impact, the financial impact. So these are all really important things, and we're thrilled that our first results are being published in the Lancet Obstetrics, Gynaecology and Women's Health. And we're also really thrilled that the first results paper is very much based around the women's experience rather than more clinical aspects of the disease. So we hope that this data will help drive change in the specific countries.
Well, we can go a lot into the data itself and the quality of the data of this particular study. But you mentioned there about the link with the Lancet Obstetrics, Gynaecology and Women's Health, this journal that only launched this year, of course, as well. And the authors of the paper in that journal have said that, to the very best of their knowledge, this is the first time that a study has collected detailed information on the ovarian cancer experiences of women in lower middle income countries. And you mentioned that there has been a previous Every Woman study from, I think it was 2018, but this is building on that. But the real difference is the demographic, the areas in the world and the lifestyles and the locations of the women who are experiencing this.
That's correct. So we've had just short of 2,500 women participate through 82 hospitals in 22 countries in LMIC across Asia, Africa and Latin America. And it's through the real hard work and dedication of our country leads and their teams that we've been able to do this. Women participate by filling in a paper survey. They could do it online by email or WhatsApp. They could fill it in on a clinic device, or they could choose to be interviewed by a member of the research team on site. And we had the survey in a total of 29 languages, including English. So we made it as widely accessible as we could.
Amazing. And again, we can go into the data and we will go into the data, of course, because the fact that it's such a broad study and so detailed and so inclusive and accessible is fantastic, of course, because you just don't see that all that often, unfortunately, in women's health, which we'll come on to talk about in a lot more detail. I wonder, though, you would have worked along so many incredible colleagues and clinicians in all 22 different countries who contributed to this study. You must have heard some incredible, and I can only assume at times really quite harrowing stories along the way. Are there any particular stories that stood out for you?
There have been many that have touched along the way, I can say that. And I know they touch the clinicians that work with them. And you'll hear that from Dr. Aisha Mustapha a little later. But it's the stories of how hard these women who participated had to work to actually get a diagnosis and to be able to undergo some treatment. We had a story, for example, in Nepal of a young woman who had an ovarian cancer and had it surgically removed. And then she disappeared back to her home, and the clinical team were contacting her because she needed chemotherapy. But she couldn't come. She couldn't afford the transportation for the 500-mile journey back to the hospital. So she disappeared for a period of 6 months before she reappeared, before she was able to start treatment. Another one where a woman was diagnosed with ovarian cancer, having tried various routes, which all cost money, to try and get a diagnosis. She was diagnosed with ovarian cancer, and her husband, this was in Africa, on finding this out, abandoned her, not only leaving her, but also removing her from his health insurance.
Wow.
So she'd had one cycle of chemotherapy and then she couldn't have any more because there was nothing to pay for it. So she disappeared again. Come back months later, her brother has now put up money and put her on his health insurance, but you have to wait 3 months for that to kick in. In the meantime, the cancer has advanced. These stories are real persistence, of real dogged determinants, but we see from the results, and the results that are in the Lancet Obstetrics, Gynaecology and Women's Health, the huge financial impact of getting a diagnosis and treatment were really the key things that really hit me, particularly the diagnosis.
Yeah.
To not even be able to afford to get a diagnosis, never mind decide what you do about it afterwards.
It's why these stories are so important, and this podcast is so important, because it's not to diminish anyone's experience of ill health or ovarian cancer in this case. But, we have so far, at least, really only heard from high income countries and women in those settings. And whilst I suppose there can be a shared experience of the financial difficulties and the constraints, it's a whole other thing when you're talking about, I couldn't get 500 miles or whatever it is to the nearest clinic to get the treatment that I needed. So much of what we've heard so far, certainly anecdotally that I've heard, is about people in those higher income settings who are talking more about being told that, that the diagnosis simply wasn't there, it was misdiagnosed, and that the doctor has said to them, go to a spin class or something like that, or you're showing signs of obesity rather than of cancer. So it's so important, isn't it, just to look at this through a different lens, because there are so many shared symptoms and shared experiences, but also so many massively different ones as well that we need to highlight as being just as important.
Yes, I think our first study showed a common set of problems, but that each country varied according to how they were impacted by these problems, some to a greater extent, some to a lesser extent. And this is exactly the same as we found in this latest edition. And there are some commonalities. Yes, for at least a quarter of women, they go through quite protracted misdiagnoses or delayed diagnoses because they've been tested for something else, treated for something else, making repeat visits back to a doctor.
What are the key findings? What are the key data points that you've been able to draw from this latest study, perhaps even just in comparison to the study from 2018 as well?
We can't directly compare the results from the first to the second study because they were carried out in different ways, but there are definitely some similarities and some differences.
Okay.
Knowledge of ovarian cancer as a disease, of the symptoms of the disease, very low. Just 1 in 4 women in the LMIC edition had heard of ovarian cancer and knew something about it. The financial impact, which I've mentioned already, just under a half of women say their family finances have been affected to a very great extent. And a third of these nearly 2,500 women say their family finances are now such that they don't cover their basic costs as a direct result of their diagnosis and their treatment. And it's important to say that in different countries, women pay or don't pay in different amounts, depending on their circumstances. So in a country like Malawi, for example, the CA125 test, which is considered a very basic test in the early steps to diagnose ovarian cancer, has to be paid for. So only 15% of the women who took part in Malawi had had a CA125 test before they were diagnosed with ovarian cancer. Women having to pay for scans, that might be different amounts in different places, even within a country. All these differences are really important because it helps build a picture by country of where some of the key issues are. In some countries, access is much quicker and costs less or costs a woman less. But in other places, it's really quite a significant barrier. And women's lack of knowledge, together with sometimes doctors' lack of knowledge, can really lead to protracted times in diagnosis, which we want to avoid at any cost, no matter the location.
Yeah.
In some countries, we see good practice. We see where women, for example, in Uzbekistan and Kazakhstan, they're much more motivated about their own health and say it's their responsibility as a woman to go and seek help if something's not right with their body. This was in contrast to the other countries that we had data from with the women. So there are many factors at play here. There aren't easy solutions, but these variations in levels of knowledge, the variations in access to treatment, the variations in diagnosis time, all of these issues show us that we can do better and we can learn from each other, even from learning from other LMIC countries.
And I think as well, one of the key things that this podcast is hoping to do is to reach not just patients and those with the direct or the indirect experience of ovarian cancer, but also policymakers, to try and really move the dial on how ovarian cancer is considered, how people are aware of it, and how it's then treated and managed. And I guess this data from this study is so valuable because it can be used to really drive change when it comes to healthcare infrastructure in a country and how healthcare is financed in a country and that sort of thing as well. Is that what your hope is, as that this study will not just reach those people who have been silenced perhaps so far, but it will also reach those people who can really, really make a difference?
We definitely hope so, at a sort of global level, if you like, raising the issues within ovarian cancer and the importance of them and the importance of taking action. So we know that incidence of ovarian cancer will go up quite significantly by over 50% by 2050. Mortality will go up as well. But it's the low and middle income countries in particular that are going to be hardest hit by these. So in some countries in Africa, they'll see more than a doubling of cases by 2050. So this is going to be a really significant issue for them going forward. So now is really a time where we can raise the profile of the disease globally, show the importance of women in society, the roles that they play, the economic contributions they make, and how important it is to hold on to that life and give these women as long and as good a life as possible with this condition. At a national level, yes, we do hope it will give data, it will give rationale, it will give emotion as well to the need for countries to consider how they can do better for their women with ovarian cancer. And we are already seeing this, even though our first results are only just being published. So, for example, in Kazakhstan, ovarian cancer has now been included on what they call the green pathway, which is a faster route to diagnosis, and a less costly route to diagnosis. And they are also have introduced genetic testing now for women, which hadn't been there before. It had been for breast cancer patients, but not for ovarian cancer patients. And that work has come out of the Kazakh team involved in the study and sharing this data. In other countries, for example, I know in Brazil, there's been a white paper put forward about the differences between the public health and the private health system treating ovarian cancer, asking for changes in the public health system as well. In other countries, Malaysia, they saw very clearly from early on in the study that women just weren't getting any support that they really did need to help them cope with having this illness and going through treatment. And one of our patient advocates, who was on our oversight committee, together with the clinical team in Malaysia, have now founded Ovarian Cancer Malaysia.
Fantastic.
And so we are seeing these changes happen all along, and you'll see some when you talk to Dr. Aisha Mustapha as well.
Yeah, we're hoping to connect up with Dr. Aisha a little bit later. Frances, thank you so much. Stay on the line, if you will, because I want to introduce now Sonia Muliyil, who is the editor-in-chief of the Lancet Obstetrics, Gynaecology and Women's Health, the journal that's been launched just this year in 2025. And we've already made mention of it as well. Sonia, thank you so much for joining us. You're publishing this Every Woman Study, LMIC, with a paper in your journal. In your view, what do we now know about the particular barriers or the particular challenges that exist in low and middle income settings when it comes to women's health broadly, but also particularly when it comes to ovarian cancer?
Yeah, thank you. It's a real pleasure to join all of you today. I think there are several barriers that exist in low middle income countries, and I think Frances very nicely touched upon some of these around knowledge, awareness, financial hardships, and at times stigma. And I think stigma plays a very important role in cancer diagnosis, just because of the reasons that Frances talked about. It leads to repercussions within the family of the woman who has been diagnosed with ovarian cancer or any form of cancer for that matter, because it has long-lasting impact on the relationships that she has, not just with her partner, but with also her kids. We have heard stories wherein women had to hide their diagnosis from their children and family just because they were worried that a diagnosis of this kind might be interpreted as something that's transmitted to the next generation or the progeny. So in other words, they were worried that their kids might be inheriting this problem, and that could actually have more intergenerational impact. So I guess stigma does have a very important is an important issue, and it did come up in the particular study that we are discussing today. But going beyond that, I think one of the important things that was highlighted by this particular study was the association that decreasing levels of knowledge of ovarian cancer were associated with lower education level, lower human development index, and lower household income, which kind of indicates that knowledge may be expected to rise as HDI or human development index rises, or if the woman has a better income, a source of income, or a better sort of source of support of income to supplement her treatment guidelines and treatment care as such. So I think that's an important fact that sort of emerged from this study. And there was also a very interesting observation that there's a striking variation among individual countries, even within low middle income countries, in terms of participants' knowledge of ovarian cancer between and within human development index groups. So that's another sort of take-home message from the paper.
Yeah, and Frances, you mentioned before about the awareness issue and knowledge, as Sonia was just alluding to as well, that I think from the Every Woman Study, LMIC Edition, that it's something like 30% of women globally who haven't heard of ovarian cancer, which just seems absolutely baffling. I know that hopefully we can talk to Dr. Aisha about Nigeria specifically because it's even higher, the lack of awareness in Nigeria. Did you find that just the knowledge, the awareness was varied dramatically from different lower middle income countries, just country to country?
It did very much. What lies behind that, we don't quite know. Yes, as Sonia has mentioned, you're less likely to have knowledge about ovarian cancer if you are in a lower HDI, Human Development Index country, if you have a lower family income, if you had no formal education versus having primary or secondary education versus tertiary or higher education. And she makes the point very strongly, and this holds true throughout all of the results in the study, not just the ones that are presented in the Lancet, that if you live in a lower HDI country, if you have lower family income, if you are less well educated, and if you live a long way from the hospital that would be treating you for your cancer, your outcomes are more challenging as a result of that. And that it's really important that any steps that are taken to try and improve the situation for women with ovarian cancer in these countries directly address those populations. We often see awareness campaigns in big cities or, directed at sort of well-educated people. We really need to get down to the nitty-gritty with this. It's about looking what really goes on for the most people and trying to make sure that we do our very best for them.
Yeah. And Sonia, was that really the driving force for you wanting to launch this journal this year? Was the awareness or the lack of awareness globally for women's health? Was that sort of the main reason why you felt now was the time and it was absolutely vital?
Partly, yes. The lack of good quality data, the tendency to relegate women's health issues to a specialty or niche domain, and often to hushed conversations. Again, the stigma associated with it, issues such as heavy menstrual bleeding are still discussed in muffled whispers and tones. I mean, it's unbelievable in this day and era. Why are terms such as vagina, vulva, and even miscarriage banned or blocked on social media platforms? I think those are the issues that need to be sort of advocated for and discussed more widely. And to me, these are the major barriers which we as a journal would really like to circumvent by publishing good quality data and serving as a platform sort of for continued advocacy on all topics related to women's health. But in terms of time, I believe at this point of time, there have been lots of developments this year, including a very strong backlash against guidelines and, advocacy around reproductive and sexual health for women, with complete erasure of guidelines and others, which make it even more important for us to advocate more widely.
Yeah, I was really struck by your launch video as well for the journal when you talked about, that historically women's health has been reduced to solely reproductive and sexual health as well. And of course, we know that it's so much broader than that, but also it's been reduced and confined to those hushed conversations, as you say. And how do you go about breaking that taboo around women's health? Because, I know as someone who's been very active in sort of the fertility space, for example, but I know that still talking about terms like vulva, vagina, as you say, that it's difficult even amongst my friends without even a kind of like a wry smile on your face. And so if that's the case in higher income countries, in highly educated spaces, amongst women who are kind of, friends and all the rest of it, then I can only imagine what it's like in stigmatized communities and societies where women feel like they can't even talk to fellow women about what they're experiencing.
Yeah, totally. I completely, align with your thoughts on that topic. And I have to say that, yes, there is a very strong misconception that women's health is equivalent to just sexual reproductive health. But there's so much more to it, and we need to keep revisiting this topic in many different ways. Cardiovascular disease, for instance, remains the leading cause of death amongst women. Very many women don't even realize it, and the risk factors are often disparate and distinct from those in men. Mental health issues like premenstrual dysphoric disorder, postnatal depression are solely associated with women and not men. And even certain conditions such as anxiety and depression are much more prevalent in women than men, autoimmune disorders, and so many more. I mean, I can go on that topic, but I think it's important to sort of ensure that these different studies and findings make it to the general media, that it's actually press released, that they are spoken about in a manner that it's no longer stigmatized. And these topics keep appearing on the news feed in different forms. But for that to happen, you require good quality data to support these topics and findings. And that's where we come in, to ensure that the quality of data is good enough, that we are constantly ensuring the good papers get press released and they are out there in the public domain for it to be discussed, debated. And even if people don't agree on it, it's totally fine. At least there's some discussion which moves the needle forward.
On the issue of women's health as well, and whether it's, something that's directly impacting a woman, we also know that women's health is also of interest to men as well, and not just because of your family members and everything, but even I think the Every Woman Study LMIC edition would show that as Frances, as you alluded to before, that there were many cases where women's health and their ovarian cancer experience was massively impacted by the men in their lives. And so it's important to have that data input as well, not just to educate men and make sure that men are globally are aware of this, but also just to also inform the data and then inform the policy that hopefully comes about as a result of it as well. So it really is kind of like something that's absolutely vital to have that quality data, that it's a women's health disease, ovarian cancer, of course, but it's not solely of interest to women.
Yeah, and if I may add just one more point, which is that there's a very powerful economic case to be made to invest in women's health. And I directly quote figures from the World Economic Forum report that states closing the women's health gap could actually unlock $1 trillion in annual global GDP by 2040. So that itself, showcases the economic case behind investments in women's health. Yeah.
And also, empowering women. And we talked about this with Christiane Amanpour in the last episode as well. And she was saying how, knowledge is power and women really need to advocate for themselves. And I wonder what you think both of you really think that the link is between health and empowerment.
Again, just quoting figures from the World Economic Forum report, which states that closing the women's health gap could yield 75 million disability-adjusted life years annually, which is the equivalent of adding 7 healthy days per year per woman. And this, in turn, would help women not just live longer, but also improve the quality of life for women, be it during menopause, post-childbirth, or even those who suffer from gynecological conditions such as endometriosis, helping them return to work, help them participate in the workforce and do much more about their lives and beyond. So just taking an example of endometriosis as a case, which we actually highlighted in our third issue, the November issue, which is supposed to affect around 10% of reproductive age women worldwide, but the prevalence is believed to be even higher. But regardless of the exact figures, the toll it takes on the physical and mental health of women is profound, often forcing them out of work and normal life. And to me, endometriosis perfectly encapsulates the challenges in women's health: underfunding, under-prioritization, and under-recognition. And while the world sort of is now waking up to its impact on women and their loved ones, I think there's so much more to be done to ensure that the right treatments are given in the right time, to ensure women, especially young women, are able to live a longer, a better life and participate in work and other things.
Frances, you're nodding along.
Yes, I am. And I'm very much for empowerment of women when it comes to their health in all settings. But I know from my experience over the last 2 decades working with women who have ovarian cancer, empowerment is really important on a lot of levels. There are so many barriers that are put in the way of women getting help, being treated respectfully about how they're reporting changes to their body, what's happening to them. That empowerment is really important. Awareness is really important. It may not even be that women need to know the exact symptoms of ovarian cancer, but they need to know that if something is not right for them, they can step forward, they can be listened to, and they can be investigated appropriately. And having some knowledge about ovarian cancer and the disease. I used to work with women in the UK who had the disease, and I would encourage them to say the words ovarian cancer if they went to their doctor, just to raise it. And you can say, tell me it's not, but I am concerned that it may be this.
It could be.
And in our first study, we showed that there was some evidence that women who knew more about the disease, if you like, were more persistent about having gone to their doctor. They kept going back if they didn't get the right route to diagnosis. They knew something was wrong. And that's why empowerment is really important. Women need to be able to go to a doctor. They need to be able to afford to go to a doctor, and they need to be able to get the right tests in a timely manner, and then hopefully get the right treatment.
Yeah.
Our LMIC study did show quite a big difference in the access to treatments. Basic chemotherapy generally was okay, though a couple of countries had significant issues during the course of the study. But access to treatments that are now considered standard, such as bevacizumab and PARP inhibitors, were very, 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 very varied. There wasn't a single African woman in our study who got access to a PARP inhibitor. So there are huge challenges. We need women to step forward for themselves, but for also other women as well, to come forward and tell their stories.
I think what you're highlighting as well is that the importance of studies like this and the data that they bring forward, and that how that can then really impact, first of all, being published in something like the Lancet, and then hopefully driving the policy change as well. Now, Sonia, I know that you're a scientist by training as well. And whilst the Lancet isn't involved, broadly speaking in this, the data that's published in your journal can potentially lead to real changes at the policy level as well. Is that one of the things that you consider when you're thinking about publishing a study in your journal? Is it that this is just interesting, or is it also that this can actually lead to a policy change?
Yeah, absolutely. We believe in publishing high-quality, evidence-based data that can change clinical practice and social norms in women's health. And often we do so by partnering with individuals in organizations such as the WHO, UNFPA, RCOG, FIGO, and several others who are really at the forefront of discovery-based research and the leader of projects that can influence policy. But we also are conscious of elevating the voice of women with lived experiences, publishing their findings, their experiences, and sharing wider press release of the main layman's summaries to the wider audience, as I mentioned before, influencing policymakers and governments, pressurizing them to use this evidence to change guidelines and national laws that can create meaningful impact. And that happens through several Lancet commissions, series, and many others. So it's very much a common practice. But I have to go back to the data part, because I think data is absolutely crucial to drive change. And I think it has been a big barrier for the women's health field, because a lot of clinical trials in the past never really collected sex disaggregated data. And this is also because women have been historically underrepresented or excluded from clinical trials, especially pregnant and lactating women. And this exclusion also sort of shifts evidence generation from the monitored setting of clinical trials to clinical settings where data can take several years to come. And it's poised for a big change, because now a lot of different studies organizations are adopting the SAGA guidelines. And there's been an institution of a global task force by the WHO to tackle this long-standing issue aimed at achieving the timely and ethical inclusion of pregnant and breastfeeding women in clinical research. So yeah, there's hope.
And I don't want to sort of like overplay my hand on this, but the data being so important in the Every Woman study, what was it in particular about the data from this study that made you think, yes, this has to be published, and we want to partner with the coalition to get this out there?
coming back to lived experiences, I think it's so important to capture the lived experiences, patient experiences. And this particular study is just amazing in terms of the breadth and scope of data collected from 22 LMICs and almost 2,500 women with experiences of ovarian cancer from early to late stage of ovarian cancer. And I think that rich data set has so much to offer in terms of changing policies, in terms of changing guidelines and practice. So I think that's one thing that we are very conscious about, capturing the voice of women with lived experience. And it really resonated with us as a journal.
Well, we always ask our guests on this podcast what gives you hope as well. So I'm going to put you on the spot a bit. But Frances, I suppose coming to you with this Every Woman study, LMIC, and your pivotal role in bringing it to the fore, I wonder what gives you hope and what gives you hope for the future in terms of moving the dial on ovarian cancer?
I do hope that the study does move the dial in some respects, in countries in particular, in communities. The people that give me hope are actually the clinicians out on their front line who were so passionate about being part of the study. They are from countries where cervical cancer is a bigger issue, if you like, at present, but they really, really feel for those women that they treat with ovarian cancer. And Dr. Aisha will be able to talk to you about this, but she said that the study really has given her a voice. Country leads such as her now have data that is useful, that is relevant. People are taking an interest. So I do think things can begin to change. And that's what gives me hope. It's seeing things move from that data, from the data on the page. And we have spent hours and hours, days, weeks, years looking at it. But now we can actually begin to see things happening, changing on the ground. It's not for us to dictate what each country needs to do. But those country leads really are beginning to take up the mantle and look quite closely at what they can do with our support.
Yes, progress and momentum, I suppose, as well, which is obviously what, through the course of this podcast as well, we're really hoping to shine a spotlight on as well. Sonia, to you, what gives you hope?
I think the passion and drive I see in the community whenever I go to conferences, the powerful essays and lived experience pieces that are submitted to us as a journal. And finally, the possibility of creating even the slightest impact on lives of those who have been historically unheard and dismissed. I think that's what drives me forward.
Well, thank you both so much for joining.
No, thank you. Thank you for having me. And the pleasure's all mine. Yeah, good luck with all the good work.
Thank you.
Well, I'm delighted to say that I'm now joined on the podcast by Dr. Aisha Mustapha, who is a consultant obstetrician and gynaecologist in Nigeria. Dr. Aisha, thank you so much for being on the podcast to start with. I know that you were absolutely integral to this study being carried out in Nigeria. You were a clinical lead. Tell us what that role really means. What does that entail? Because you must have built some amazing relationships with women along the way.
Yes, thank you very much, Hannah. I'm very happy to be here. And yes, I was a country lead for the Every Woman study, meaning I led the study in the entire Nigeria across 12 sites. And these 12 sites were distributed across the 6 geopolitical zones of the country. And Nigeria is very large, is very diverse. So I was able to work with clinicians from different sites managing women that had different cultures, and there were different challenges with those women. I was able to meet with them very frequently. It helped me to actually build a research team and made me understand the different challenges we had in different regions of our country to see how to do a collaborative research study. So for me, it was an experience that I gained and also lasting relationships, not just with the women that we interviewed, but also with the clinicians that were managing them.
Because we were hearing earlier that this has been more than 2,000 women in this study from 22 countries as well. And you're talking just about, the differences in locations and experiences of women just in Nigeria itself. How many women and their experiences from Nigeria were included in the study. And I suppose tell us a little bit about some of the stories from these women that must have really stood out for you.
For us in Nigeria, like I said earlier, we recruited women into this survey from across the 6 geopolitical zone, and we recruited a total of 204 women spread across the 6 geopolitical zones. And their stories were similar in some aspects, but quite different in others. And I remember particularly a patient who told us that she was diagnosed with an early stage ovarian cancer at stage 1, suspected ovarian cancer. And she was diagnosed during the peak of the rainy season, and she was not going to be able to afford treatment until the harvest season, meaning that is when she'll be able to get her crops harvested, sold, and then she gets some money to come back for her full evaluation. So that particular story struck me very, very, very deeply. And another woman told us that she had retired from civil service. I mean, this is the minority of women that were fortunate enough to work for the federal civil service. And she had retired, and what she did with her entire retirement savings and gratuity was to manage her ovarian cancer. So she had to relocate back to the village and then having nothing else to fall back upon. So we had so many stories that were very touching as we surveyed these women for their ovarian cancers.
Yeah, amazing. Particularly that first story you mentioned about someone being diagnosed at stage 1, because what we're hearing so often is that people are getting a late stage diagnosis. And so the fact that it was at stage 1, it could have been managed so much more easily had she been able to afford the treatment, which is just another barrier that we're seeing from this particular study focusing on low middle income countries as well.
Absolutely.
And we were hearing earlier that there's something like 30% of women worldwide who have never heard of ovarian cancer. That stat is kind of shocking, I think, to most people anyway, but it's even higher in Nigeria. It's nearly 39% of women in Nigeria unaware of what ovarian cancer is. How do you explain that? Why do you think awareness is so low in your country?
Yes, ovarian cancer awareness is very low, not just among the general population, but even among healthcare providers. As in, it will be shocking to find out that even healthcare providers know very little about ovarian cancer. Now, women that have never heard about ovarian cancer prior to their own diagnosis was as high as 38.8% in our series. And this was truly significant, never having heard about the disease prior to their own diagnosis. Now, the issue about this low awareness is generally not, I don't think it's the fault of the woman, but I think it's because of the myths regarding ovarian cancer as being a silent disease. The symptoms are not there, but in our series, we found out that over 90% of women actually had the symptoms, but they didn't know that these symptoms were for ovarian cancer, and most of them were being managed for other gastrointestinal conditions. So I think the emphasis in many LMICs, including Nigeria, is on other cancers like cervical cancer. We all know that very rightly so, cervical cancer burden is very high, but it has taken the most part of the awareness creation that non-governmental organizations and even the government do. So we feel that this study is a call to action to make sure that we also talk about ovarian cancer and make people aware about ovarian cancer, make them understand the symptomatology, and make them know that when the symptoms happen, it could be ovarian cancer and not just some gastrointestinal symptoms that should be discarded. So I think it's a call for action that we should do something about this very high lack of awareness rates.
Yeah, there's the lack of awareness, and then there's just the social taboos that have been in place for generations in every country as well. I think I'm right in saying that you have your own lived experience of cancer, of cervical cancer as well.
Absolutely. That's correct.
I'm wondering if when it comes to you dealing with patients, dealing with women who are going through cancer, and ovarian cancer in this case, does your own experience mean that you are able to talk more openly, that there is a bigger sense of trust and empathy that means that you in particular are more able to help break down those societal taboos that persist?
Absolutely. I that was the reason I came out with my diagnosis. I felt that we could not continue keeping quiet, pretending these things don't happen, pretending only women who are uneducated suffer it, pretending that this is not a problem in Nigeria. So I came out with my own diagnosis to make people know that, number one, knowledge alone is not enough. If you do not go out there, for example, to get screened, if you do not go out there to check your symptoms, knowledge alone will not suffice. And then secondly, to tell people that it is beatable. So we have this norm, this thinking in Nigeria that cancer diagnosis is a death sentence. Anybody with a cancer diagnosis is seen as somebody who is going to die soon. So I use my own story to tell people that cancer can be detected early, it can be managed, treated, and cured. And then it makes people have this belief, in use that, oh, you mean you went through this yourself and you're here talking to me and treating me? So it makes it look very real and not just a statistic of people that have survived cancer and they are right here in front of you. So I go all out to tell people that I myself have had a cancer, I have been treated, I have been cured. If you come out and you are diagnosed early, you get your treatment, you can actually get treated and cured of your cancer. So I use my own story all the time, and I think it works really well. It makes people go out to get their screenings done for their cervical cancer and also come up with their own symptoms early to the hospital. And we have also taken it a step further to see how we can educate the healthcare workers that these women present to, because majority of them actually go to the hospital with those symptoms, but they are managed for something else. So we have organized webinar sessions with healthcare providers at the primary level, where we explain to them that when women come with these symptoms, especially if they are within this age range, please look for ovarian cancers. A transvaginal ultrasound or even a transabdominal ultrasound could just be the lifeline to giving them that early diagnosis.
Well, your work is so important. And I know that you've taken it another step forward as well with this Nigeria pilot scheme that I mentioned at the very beginning of the podcast in the introduction. And this is this exciting project which has data at its very, very core. Tell us about how it came about. I guess it was very much informed by the Every Woman study, LMIC.
Absolutely. It was 100% informed by the Every Woman study, LMIC. So prior to the Every Woman study, to be very honest, nobody discusses ovarian cancer. We belong to a group called the Nigeria Cancer Society Stakeholders Forum. And in a year, ovarian cancer is probably not mentioned on that platform prior to the Every Woman study. So it was all about other cancers that we felt had a higher burden in Nigeria. And after the Every Woman study, the findings were very significant, very alarming. And I was so pleased with the World Ovarian Cancer Coalition because they didn't just do the study, have the data and leave. They ensured they stayed behind, interacted, reached out to relevant stakeholders in Nigeria, formed coalitions, formed collaborations and partnerships to see how we can use these results to actually better the ovarian cancer landscape in Nigeria. And that was what birthed the pilot. So we had organizations like Medicaid, and very key was the National Institute for Cancer Research and Treatment, NICRAT. They oversee cancer research and treatment, and they got interested in the results of the Every Woman study. And then the talks began, and very quickly they bought the idea. There was a collaboration, stakeholders were invited, everyone was willing to support. And here we are, already launched the pilot project on 14th of October. For me, it's something I'm super proud of. This is a collaborative research that has yielded the most positive progress moving forward. And I'm really looking forward to the results of those pilots. We have other organizations interested to key in, and I'm very optimistic that this pilot will actually change the ovarian cancer landscape in the country.
It's an amazing pilot. I know you said it's only just launched in October, but the whole point of this podcast and what the World Ovarian Cancer Coalition is trying to do is to move from research to data to informing policy and real change as well. And it sounds like this is something that hopefully could be replicated in other countries as well. Aisha, before you go, one of the things that we ask all of our guests on this podcast is what gives you hope? Now, you sound to me like a joyful, hopeful person, but when it comes to ovarian cancer, which often the stats we know are so dire in so many settings at the moment, do you still have hope when it comes to looking at the ovarian cancer space and what that might look like in 5-10 years' time? What gives you hope?
Absolutely. I have hope. A lot. I am very optimistic that the ovarian cancer landscape will get better in my country. And the reason is because, like I said previously, we're not even talking about it. Today, we are not just talking about it. We have stakeholders that have bought into ovarian cancer prevention, early diagnosis and treatment. We have our National Institute. I mean, it is the highest body for cancer research and treatment and cancer funding and everything about cancer in Nigeria. They have bought into ovarian cancer, and they did not just buy into it. They have actually made contributions to how we can organize the pilot and also take it forward. We have seen them try to establish genetic testing for ovarian cancer patients. Now, in the cohort that we studied, only 5 women had genetic testing, and all of them were based on research where they were enrolled upon. So we do not have it in Nigeria, but today we have organizations that have been in talks to establish genetic testing for ovarian cancer patients. These are very giant leaps in very short period of time. So in 5 to 10 years' time, I see us having at least the standard of care for everybody that has been diagnosed. I see us going further to actually do risk reduction in women that are at high risk for ovarian cancer. And I see the data getting better and not just estimates, because that is also being worked on. So I see a lot of change in the current landscape that we have moving forward for the next 5 to 10 years.
What a hopeful note to end things on. Dr. Aisha, thank you so much for joining us and for single-handedly changing the ovarian cancer story, certainly in your country as well. Thank you also to everyone listening and watching. Remember that you can follow us on your podcast app to get every episode in your feed, and do please press that subscribe button on YouTube as well. This series is produced by Annabelle Deegan and Jessica Martinez de Hoz, with the support, of course, of the whole World Ovarian Cancer Coalition team. I'm Hannah Vaughan-Jones, and until next time, keep well. If anything in this podcast has affected you and you would like to speak with someone, you can also contact your local ovarian cancer patient group. To find your nearest ovarian cancer groups by country, please go to partners.worldovariancancercoalition.org.